Hello class, this is Dr. Briscoe. In this lesson we're going to look at some of the skills associated with elimination in nursing 113. For validation, you're going to have to insert a urinary catheter either into a male or female. You're going to have to collect a sterile urine specimen. You're going to have to perform closed intermittent irrigation, and then you're going to have to discontinue the urinary catheter. Some other important skills are listed here as well that you need to be familiar with, particularly, if we're at the hospital, and you may see some questions on the exam about some of these other skills too, because most of them we've already talked about or we're covering with this unit. This slide shows you various types of catheters. The triple lumen catheter is used when you want to have a continuous irrigation. An example of that would be when a client has had a prostate type surgery that they're passing a lot of blood through their urine and has to be continuously irrigated to keep the catheter from clotting off. So you see A is a so shown here is the Foley catheter kit. It should contain the things that are listed here. You need to become familiar with how the kit's set up when you're practicing. So I want to encourage you to get your skills checklist out and follow it. I'm not going to go over every point that's listed on the skills checklist. You need to be sure and ensure privacy for your client. Position your client semi-Fowlers with their knees pulled up and spread apart. You should be sure to do peri-care before doing the catheterization. And you'll want to put your kit, if your patient's cooperative, between their knees. Don't forget to use sterile technique. Don't forget how to put on your sterile gloves. That's a component of the checkoff. And this just shows you applying the non-dominant hand first. You're going to get your supplies within your kit set up. You'll open the swabs or the betadine pouch and pour it over the cotton balls. You'll attach your saline syringe that you're going to inflate the balloon with. You'll go ahead and attach it to the port, but we don't go ahead and check the balloon by pushing the fluid in outside of the patient. That's not recommended anymore. If you saw people do that before, it used to be the thing to do, but it's not now. You will take the plastic cover off the catheter tip. You will place some lube in a tray and place the catheter tip in that lubricant. And you're going to maintain sterility within that kit while you're doing all of this. And so you've got to be mindful of that relative to, sometimes I see students let the tubing flop off the drape that all the supplies are left in, or I see patients touch the equipment with their knees or legs or something like that. So you've got to be mindful and pay very close attention to what you're doing while you're doing it with a patient and during checkoff. For females, I just wanted to show you this because oftentimes students try to catheterize the wrong spot. And so with your non-dominant hand, you're going to separate the labia majora, and this hand is not sterile anymore, so you cannot use it within the kit after you've done this. And you're going to locate the urethral meatus, and it's under the clitoris and above the vaginal orifice. And so you see a lot of people want to catheterize the clitoris, or they want to catheterize the vagina. But you'll see right there it's in the middle. And so that's where you're wanting to shoot for. A good tip on this is before you get ready to catheterize the first female, you might want to have your instructor get some betadine and y'all wipe and look for the opening so that you can tell where to put the tube. Because if you stick the tube in the wrong spot, you're contaminating the tube and you have to get another catheter. So you want to cleanse the patients with betadine unless they're allergic with one swipe down per cotton ball. You do the inner, the outer, and then the middle. You want to hold the catheter with your dominant hand and ask the client to bear down gently as if they're going to void. And you'll notice how in this picture it shows her holding the catheter where the tube rests on the hand. This prevents the tube from being contaminated with the arm if you hold it over the top. So I've saw lots of students contaminate their tubing with their sleeve or their arm if they're holding it over the top of it. You want to insert the catheter into the urethra and advance it 2 to 3 inches. And once you have urine draining into the catheter or draining out of the catheter, you want to advance it 2 to 3 more inches. Don't force it. If it doesn't want to go in, ask the patient to breathe deeply and rotate the catheter to try to gently get it in if you meet some slight resistance. Once you've finished inserting it, you want to take your non-dominant hand and hold on to the tubing and take your dominant hand and go down and inflate the balloon. The balloon typically holds 10 milliliters of normal saline. And once you have inflated the balloon, you need to be sure and take the syringe off the port, because it can just deflate right back if you don't. For males, you want to retract the foreskin, and you want to do that too, but while you're doing the pericare. And you want to keep the non-dominant hand on the penis and keep it away from your sterile supplies. You want to cleanse in a circular motion downward ×3 and hold the penis slightly upward with tension. And with the lubricant on the with the big difference with this is you're going to, rather than shooting all your lubricant into the tray, you're going to leave some of it in your syringe. And when you're ready to do this, you're going to actually take that lubricant in the syringe and shoot part of it straight into the penis. What that does is open up the penis really well, and the urethra is really wide open. And so then you're going to take your catheter and insert it. So you want to insert it until you get flashback of urine, and you will be close to that Y port with a male. You'll find that it seems like you're really sticking in it in a long ways. And so when you get flashback, again, you want to try to insert it 2 to 3 more inches. But you can't insert it beyond the Y, obviously. And then you'll inflate your balloon. Once you inflate the balloon on both patients, you'll just pull back gently and make sure that you're going to get a little resistance, and that way the balloon is in there in the bladder. You want to dispose of your equipment, preferably not in the patient's room, not in their bedside garbage. So get that out of the room. It's just too much stuff. And again, don't dispose of your catheters when you take them out in the room either. You should take them to the biohazard. Document your catheterization. You want to document the size the type of catheter, the size, the amount of urine that you get instantly. You want to document that you maintain sterility and that you dated. You should date the stat lock. The stat lock holds the tubing on the leg and keeps it from pulling or prevents traction. So again, you're going to secure the catheter tubing to the patient's inner leg and make sure they're comfortable. Date that stat lock. I think I've got a picture of one in a few minutes. Secure the drainage bag below the level of the bladder. Make sure there's no loops or kinks. Don't hang that bag on the railing. Don't let the bag sit in the floor either. If you do need to get a urine specimen, you want to look at your policy. If it's just a urinalysis, then you could just go ahead and get it from the bag immediately. But if it's for culture, I probably would collect it from the port. That way it's like you're getting a clean catch. A straight catheter is a temporary catheter where you just put it in, empty the bladder, and take it back out, or put it in and get a specimen and take it back out. So it's very similar, other than you're not blowing up a balloon and you don't have a bag. You just let the urine flow into the little box that comes with the kit. This just shows you a stat lock that you will put on the patient's leg to secure the tubing, and just shows you the bag itself. This shows you a leg bag. If your patient is going home with a urinary catheter, you'll want to help them change from the larger bag to this smaller bag using a sterile technique with your tips, and help them get this on their leg and show them how to do this. This is something they'd wear in the daytime. You can see it doesn't hold as much, so they can just go to the bathroom and empty it when they need to, when it starts getting a little bit heavy. But this is not sufficient for someone overnight. They need to swap back over to the larger bag at night. If you're emptying a bag, you need to be sure and maintain the sterility of the port at the end. If you should touch it to anything, you should wipe it off with alcohol pad. You should not let that port get below the level of the urine in the container you're getting. This just shows you a bag with a urine meter on it. So you see that plastic measuring urimeter that's on the front. The way this is set up is if you pick that up from the bottom, the urine meter, it will dump the urine over into the larger bag. So if you've got somebody that you're taking Q1 hour urine outputs, you can go in there and either empty it with that little green port there on the urine meter, or you can just look at it and get your output and dump it over into the larger bag. This shows you the port that you would collect a urine sample from. So if you're collecting a urine sample, I'm going to go through the steps. This is also the same port that we're going to show you irrigation of the catheter, intermittent irrigation. So in this slide you can see there's like a 10 milliliter syringe, and so she's probably just getting a urine sample there. So if you're going to get a urine sample from the catheter, you don't want to empty the bag. If the patient's had it in there for a while, the bag's obviously not going to be clean. So what you want to do is clamp off your tubing, and there's a little green device that's on the tubing, and it's held on with a rubber band. You can use that device to clamp it, so we'll show you how to do that in the lab. That device can also be used just to clamp the tubing to the bed sheets so that it's not pulling. But you'll clamp off your tubing and wait for 5 or 10 minutes, and then come back and cleanse that port and apply your syringe and withdraw your urine, and then put it into a sterile specimen cup, label it and double bag it with a biohazard marking on it, and then be sure to unclamp your tubing. So it's really important to not leave that tubing clamped. If you're irrigating a catheter and you're using the closed system technique, we're going to show you how to do that, but there is an open system type of irrigation as well. For the checkoff, you're going to have a sterile syringe with some sterile saline, and usually though, if you're irrigating it intermittently, you may use more than the 10 milliliters of saline, and you may use a larger syringe, but you'll clean that port, and you obviously got to have an order to do this, and so you'll check your order, look at the urine's character, determine the type of catheter, tell the patient what you're going to do, put on your gloves, hand hygiene gloves. You're going to assess the abdomen for distension, position the patient semi-Fowlers, draw up your solution. But for y'all, for checkoff, you're just going to use a 10 milliliter syringe of saline. You want to clamp the Foley catheter, down below the port, and attach the syringe to it. And your example is with just a regular Foley catheter. So I have included a video showing the intermittent irrigation. You can use your syringe and withdraw what you put in rather than just letting it drain into the bag, and so the video shows the nurse doing that. She shows putting in with a big syringe, some fluid, and then putting a little bit more to get the tip of the catheter away from the side of the bladder. The reason we would want to irrigate a catheter is if it was getting clogged up, maybe from blood or mucus, blood clots, and so forth. This picture shows you a continuous bladder irrigation, and in this picture it's through a urinary diversion, but more likely you're going to see a three-way catheter in a patient in the urethra, and we typically see this set up with patients that have a benign prostatic hyperplasia or have prostate cancer and they have a removal of the prostate. After prostate surgery, they have a lot of bleeding, and the three-way catheter with a big bag of fluid, the irrigation fluid, continuously is necessary to keep the tubing from being blocked by large blood clots. And so with the continuous irrigation, the rate should be adjusted to keep the urine light pink and free of clots. We don't want to run it too fast though, because it can cause some fluid imbalances, some fluid overload and some sodium imbalances. We want to make sure that we empty the Foley catheter bag frequently, because it will get full very quickly, and make sure there's continuous drainage into the bag, because if we run a lot of fluid in the patient and then it doesn't drain back out, we could rupture their bladder. So making sure that the tubing is not kinked, making sure that the drainage is patent and it stays light pink to clear is important. That's part of the nurse's responsibility in post-op transurethral resection of the prostate care. So I encourage you to read in your textbook about a TURP and post-op care, because it is something you'll see frequently on a med-surg floor, and it's something that requires the nurse to be very mindful of managing this irrigation. Occasionally we see patients require an open intermittent irrigation, and what that means is disconnecting the tubing, the bag and the tubing from the patient, and putting a sterile syringe into the end of the urinary catheter and pushing fluid in and then pulling it back out. That would also be a sterile procedure, but we don't typically do that unless the catheter itself is getting blocked and we can't get it unblocked. And it requires an order as well in sterile technique. We want to make sure that trauma is minimized with anybody that has a urinary catheter, and that entails making sure we use the right size catheter, making sure that we lubricate the catheter with a water-soluble lubricant, and making sure that the catheter is secured to the leg. There's a box in your textbook talking about bladder retraining after someone has a urinary catheter discontinued. I encourage you to read over that. The detrusor muscle does not act appropriately sometimes once we take out the catheter, and so they may not immediately respond to bladder filling when the catheter is removed, and that can either result in urinary retention or urinary incontinence. And this is called post-catheterization detrusor instability. So reading your textbook about how to do bladder training. We may also teach patients how to self-catheterize. And there's actually a big box in the textbook on different methods to help patients that are having some problems with incontinence. If your patient comes back from surgery and gets a catheter discontinued, it's very, very important that you monitor the patient and make sure they start urinating on their own. Oftentimes they will have problems and have retention and have to be recatheterized. So if we're going to discontinue an indwelling catheter, we want to empty the bag, measure the output. We'll wear clean gloves when we do that, and then we'll have other clean gloves on to deflate the balloon. So we'll attach a 10 to 12 milliliter syringe to the port, pull back and let the syringe fill with the saline that we use to blow the balloon up. And then we're going to ask the patient, you can just leave that attached, that's fine. Ask the patient to take a deep breath and remove the catheter into a towel. It'll dribble if you don't. And dispose of the equipment not in the room, and either provide or assist the patient with peri-care after removing it. So in this recording, we've went over the skills that you're going to do the validation on. I did come back and revise this recording and take out the urinary diversions and the fecal diversions information because I realized I had already did a recording on those separately. So you have that as well. Thanks for listening to this recording. Be sure and review your skills checklist and follow those when you're doing the skills as you're practicing, because I've not really went over everything that's on those lists. Thanks so much.